Hi, Kimji. Thank you very much for having me. Another fantastic edition, 25 Biennial. Congratulations to everybody involved in making this happen. And we'll start with our topic today, which is choosing the efficient acute treatment for migraine, and we'll touch both inpatient and outpatient setting. The relevant disclosures for me, information has been taken from Continuum, American Headache Society, American Academy of Neurology, and another disclosure, I'm also advisory, part of Advisory Committee of Pakistan Headache Society. The references have been taken from different fantastic people, Dr. Marmura, Levin, and Robbie's articles as well. A little bit about me. I'm assistant professor at Virginia Tech Carilion Medical School in US, and I'm also their clerkship associate director and neurology electives director, and I supervise a multidisciplinary headache clinic. And I've done 4 boards, American, European, and British as well, and then a fellowship in headache medicine. So today's talk is going to be focusing on 4 things: epidemiology of migraine, which is super important, how to diagnose migraine we'll touch, and then there are further lectures as well, which you'll read about, and then inpatient acute treatment, and then outpatient acute treatment. The goal of this talk is when you get out of this talk, you have good toolbox to what to use in your practice in the future. So epidemiology-wise, remember, globally, 3.1 billion people suffer from some headache disorder, 2 billion with tension headaches, and 1 billion with migraine. Most commonly seen is migraine, especially outpatient. In US alone, in 2011, there were 5 million ED visits due to headache. Fortunately, only 5% were with severe headaches or secondary disorders. And then status migrainosus is one of the most common headache disorders that comes, and which related to 1/5 of the ED presentations. Status migrainosus if the migraine is more than 72 hours. And then 1 in 7, and some studies only even show 1 in 6 adults worldwide suffer from migraine. It's a huge number. And then 1 in 11 pediatric and adolescent patients from migraine globally. So imagine if there are 30 people in a classroom, 3 kids might be suffering from it. If there are like 21 people sitting in a room, 3 probably will be suffering from migraine. Goals to ensure that 2.2% patients in American disabilities EDs presented with headaches, and only 7% of patients with migraine seek headache-specific help at the emergency department. So remember, not everybody comes to the emergency because they have a headache. Only 7% people with migraine come in, and then secondary headache orders have been attributed in different ways. In pediatric, it's mostly systematic viral infection, and migraine is also the most common symptom disease which is seen in outpatient neurology clinic, up to 88%. A very interesting fact: status migrainosus can be up to 4.8 weeks average. So don't take it lightly. When a patient in status migrainosus, you have to break it. It confers high disability, and it can include a 1.814 risk of attempting suicide. And those which are admitted for status migrainosus, mood disorders, obesity, opioid overuse, congestive heart failure, and chronic renal failure can predict a longer stay. So very important for you to know is that headache is an umbrella. And then there are so many other pathologies under which can cause a headache, and which, as we talked about, most common is tension and migraine. But we need to know what's the difference between a headache and a migraine. That's a question which you'll be asked again and again. So think in a way, migraine is an episodic debilitating neurovascular phenomena, which is unilateral in 50 to 60% people, but not always. And it can have multiple associated symptoms, out of which headache is the most common and maybe the most debilitating. 1/3 of migraine can occur in children and adolescents. That's why it's important to provide good treatment at the very start. And then almost 25% are those which outgrow migraine in adulthood. Rest of them continue on that. Approach to history is important. OPQRST is one which we use all the time: onset, provocation, quality, radiation, severity, and time. It should be on your fingertips for headaches. And then remember, setting the clinician stage for headache medicine is the trump card. Why? Because if you can diagnose primary headache conditions right away by just history and neurological exam, you're saving them from a lot of tests in the future and saving financial instability as well. Only 7%, remember these 2 facts again, that only 7% patients only seek emergency treatment, and then 2.2% came to the headaches. And if you don't do the history properly, then remember there's secondary disorders which you can't afford to miss, which could be cerebral hemorrhages, RCVS, temporal arteritis, pituitary apoplexy, venous thrombosis. So that's why knowing the tits and the bits of headache disorders is so important, especially the migraine definition. For that purpose, physical exam is super important. A thorough non-focal neurological exam is very reassuring, but a fundoscopy should be done in every patient. And reminder that during the exam again, ask about pregnancy. You can't afford to give medications, which we're going to talk about in pregnancy, most of them. Treatment-wise, you always start with regularity of schedule. You talk about exercise, 30 minutes, 5 days. You talk about meals, especially breakfast. You talk about hydration, 1 ounce per every kilogram should be the goal. And then sleeping is very important from pediatric to adult. HeadacheReliefGuide.com is an excellent tool as well for habits. Migraine without aura, you know the definition very well. You should have at least 5 attacks, which have to be between 4 to 72 hours and have to have 2 of these important characteristics: unilateral location, pulsating quality, moderate severe pain, and then aggravation by causing avoidance. With tension headaches, you should not have aggravation. And then one of the following: nausea and or vomiting, or both of them, photophobia and phonophobia. This is important because in tension headaches, you can have photophobia or phonophobia, one of them. In migraine, you have to have both, or nausea. Migraine has 4 stages. We'll be talking more about them as well, but do not just think that it's only headache. That's why acute treatment is important, which can be used in any of these stages, especially prodrome and aura, other than the headache itself. So migraine is not 4 to 72 hours. It's more than 5 days. Migraine is a genetic condition, 71 genes so far, 50% chances if one parent has it, 75% chances if both, and now it's well combined. The migraine is a neurovascular disorder. It's not only a vascular disorder because the blood squeeze or dilate. It has pain transmission as well, which we target. So what are the treatment principles for acute migraine? Number 1, rapid and complete relief of pain. Number 2, prompt return to function and reduction in attack-related disability. Number 3, effectiveness at first dose, very important. And number 4, minimal side effect burden. And then obviously you have to be cost effective and easily available. So keep these principles in mind when you are going to give somebody anything from NSAIDs to triptans to GPANs, which we'll talk about. Why rapid and complete relief of pain is so important? It's very well established that a partial response to acute treatment is associated with lower patient satisfaction, a higher risk of headache recurrence, a higher burden of migraine-related disability, and increased risk of migraine chronification. So what is your toolbox? You should take a picture of this as well. In inpatient, in ED, you have a lot of medications which you can give. Most commonly which is used is ketorolac, but you have chlorpromazine, prochlorperazine, Reglan, metoclopramide. DHE might not always be available, sumatriptan if you don't have subcutaneous, but you have valproic acid, which is Depakote, magnesium, dexamethasone is easily available. And then not the favorite at all is morphine, which should be your last resort in any case. So what are the doses of them? Chlorpromazine 25 to 50, prochlorperazine 10 milligrams, and metoclopramide 10. Remember, these are T2 receptor antagonists. They have strong evidence of being used in migraine, but we don't know how they work in analgesia yet. Talking about choosing one of them in patient, you have to weigh between sedation risk and akathisia risk, because in the end, D2 antagonism, metoclopramide has moderate effectiveness and sedation risk is mild, but akathisia is moderate. The same goes from promethazine, 12.5 can be used, but effectiveness is low, and then akathisia risk is low. So you really have to tailor make as per the patient's age and comorbidities. I know Reglan is highly used, but at the same time, we don't use haloperidol a lot as well, but it has a very high mode of effectiveness at the same time. So what is the total evidence which we have? Well, prochlorperazine has a very high evidence. It's superior to placebo, sumatriptan, hydromorphone even in some studies. At the same time, haloperidol is very effective and widely available. It's used less, but it should be used more. Pentaclopramide is used high. It's also used in pregnancy. And promethazine has fewer extrapyramidal symptoms, but less effective, especially in pediatrics. Common side effects, as you know, hypotension, akathisia, and for extrapyramidal symptoms, you have to have diphenhydramine, which is also called Benadryl, with you in the ED whenever you give. Remember, they come at a cost, which is QT prolongation. That's why you have to have an EKG before you're giving these, especially in adult patients who have cardiac comorbidities. And then we also have non-neuroleptic antiemetics like zofran, odensetron, arapitan, which is mostly used in chemotherapy and domperidone, 10 milligrams. You can then use other options like Toradol, ketorolac, which is used a lot, valproate, which is divalproax, 500 to 1,000, and then IV magnesium, 1 gram, which can be used up to 2 to 4 grams as well, maximum 5 grams. Opioids, not recommended at all. Poor effectiveness for migraine relief, high ED return rates, and then myriad of side effects. But if they have no alternatives, you don't have anything, then morphine 5 to 10 IM or 2 to 5 he has to use. Remember, there are excellent studies now which shows corticosteroids being used for to decrease the relapses to ED, especially for migraine or status, and dexamethasone 4 milligrams can be used as a single dose. Unfortunately, we don't do a lot of nerve blocks in Pakistan. I know that. This should be more habitual. More people should be trained in it. Nerve block is a fantastic way to break status. There are studies which are mixed, but in our own practice, we do a lot, especially in pregnancy. You can do without steroids. You can do a long-acting anesthesia, short-acting anesthesia. And if the patient is not pregnant or is not lactating, you can also do 2 cc of dexamethasone or methylprednisolone, and it really helps them to decrease the pain. Concerning metrics, why inpatient and ED acute treatment is so important? Because if you're not treating them properly, high recurrence rate, and then patients lose to follow-up. So ED, you should give them a follow-up that you have to follow up in outpatient clinic for better treatment. So goals of inpatient treatment: reduce headache, frequency, severity, decrease disability, and set the expectation that benefits may appear post-discharge. There are patients which come with prolonged aura, especially visual aura. So there's limited evidence right now, but most probably, which we use all the time, is actually Depakote, which is divalproax, or we also use magnesium to hit the NMDA receptors, which are subtypes of glutamate receptors. And then it's also seen in some literature that Keppra, which is the levetiracetam in US, or furosemide, is also used. But mostly it's the high dose magnesium which is used. This is some of the data which has come over the time. As you can see, what's the sample size and mean pain score, which has gone down. The best one still comes as the nerve block, which you can see that the score goes up to 3.7.5% down and 3.36 in occipitال nerve block. And then you can use different combinations as well. So what should be the treatment flow? I think this is a great slide, which you should all copy. They start with IVF, prochlorperazine, and then diphenhydramine, or you can use 25 milligrams of IV, dexamethasone, and Toradol, which is ketorolac. If DHE is available and no cardiac risk, it could be used. Then after an hour, the second line should be one of the D2 antagonists, or you can use Depakote or magnesium sulfate. If still that doesn't work, then you again repeat the Depakote or magnesium sulfate. And if you have options of ketamine that can be used, which is, I know, rare right now, but the other options could include Diamox, which is acetazolamide, or levetiracetam, which can be used as well. And if still you do not have a good response, then you go for inpatient stay, which we call the Q8 markers. Then you can repeat the migraine relief therapy again and again. We don't use the word migraine cocktail anymore because the cocktail itself is stigmatized. So we use more migraine relief therapy than anything else. And then for outpatient migraine treatments, it's very important that you know that triptans are the first line, the BND agonists. It's always debated that can we use in serotoninergic medications as well. We use it because they're BND receptors. There is less data of serotonin syndrome. But remember, they're contraindicated in heart disease, hypertension, and also in hemiplegic migraine, retinal migraine, basilar aura. And the accumulated data about triptan, especially sumatriptan from Canadian guidelines, also show that there's not enough data to show that they're safe, but not enough data to show that they have been harmful. So it is used off-label often in pregnancy as well. Reason, again, history is so important. Do not miss these points, because if you are giving a patient a triptan in basilar aura, there is a chance that they might stroke out. Because again, vasoconstrictive actions should not be taken lightly. So triptans, how to use them? Optimize to the maximum dose first. For instance, if you're using sumatriptan, go up to 100 milligrams. Then repeat after 4 hours 100 milligrams. And after that, if 50% reduction is not achieved, then after 3 attempts, you say, oh, you probably failed this drug. Give this more chances. Change if there are side effects or it's ineffective, only when you have optimized and given enough chance. Remember the common side effects: tingling, flushing, dizziness, nausea. A lot of people tell me cranial allodynia, which is like the sensation is different on their head. And then less common but important, palpitations, elevated blood pressure, and then some side reactions as well. So how to use? Choose per duration, side effect, and severity. I know we have limited options in Pakistan right now, but start with sumatriptan. Remember, the half-life is 2 hours in oral, and one which bypasses the stomach have higher half-lives. But if sumatriptan fails and there are side effects, go to rizatriptan, zolmitriptan, elatriptan, elmotriptan. And then if the patient, for instance, like patients with menstrual cycle or catamenial headaches or migraine, use longer half-life like naratriptan or provatriptan. So again, if you're having ineffectiveness, bypass the stomach. But if you're having effectiveness, but the side effects are more, then you go towards the longer half-lives. Be cautious, and very good thing. This was one of the first questions in my headache board as well, that which triptan should not be used with propranolol, and that's actually rizatriptan. It should be used lower dose because propranolol slows the rizatriptan metabolism and increases the level by 70%. And then if one triptan fails, using the second one gives a chance of 25 to 21% success. So how do you choose a good plan? And this is very important as a headache physician, as a neurologist, as a primary care provider, as an internist, as a family medicine doctor, for everybody. Ask patient to scale their headaches out of 10. That's the first thing. 1 to 4 mild headaches, 5 to 7 moderate headaches, and then 8 to 10 severe headaches. Once it's done, then this is the way your plan should be. Fabric their plan as per the severity. For instance, first of all, you have to tell them lifestyle modification. What is it? Go to a dark room, turn off the lights, get hydrated, and keep a cool compressor on your head. Number 2, pragmatic approach. Give them autonomy. For mild to moderate headaches, once you have established what is 1 to 4, 5 to 7, 8 to 10, first of all, use NSAID if you have mild headache. Naproxen 500 milligrams or ibuprofen 800, and then you can use every 12 hours. Take with food, and then 10 mg per kg for less than 40 kilograms patient, especially if they're pediatric. And then very, very important, limit the use to less than 15 days a month to reduce the risk of MOH. MOH is hard to diagnose, even harder to treat. So this should be the expectation straight away. When you go to the next part, moderate to severe headaches, keep one principle in mind. Migraine drives nausea, nausea drives migraine. If you are treating moderate to severe headaches without nausea, you're not treating the migraine. This is as simple as that. So for moderate to severe headaches, then give them another toolbox. Use the triptan in combination with the NSAID which you gave. And the triptan again should be used after 2 to 4 hours again if the 50% reduction is not achieved. So you have more toolbox, more tablets to give. It means triptans are there for 9 times a month on top of the NSAIDs. And for nausea, give an antiemetic like Zofran, metoclopramide, and it can be repeated every 8 to 10 hours. So what does that mean? It means that you might have to take all 3 tablets at the same time. And that's fine. Take the bull by the horn. That should be your approach as a physician, that you are giving the toolbox, that you take all 3, and then you have again to repeat 4 hours later, and if you have to repeat 12 hours later, that's absolutely fine. You are saving the patient from status migrainosus. You're saving the patient from going to the ED. And then the most important thing, which is missed often, is the rescue medication. So what's the rescue plan? So we have an acute plan with NSAIDs, triptans, and nausea. The rescue plan is, if all these fail, then you have to review an ECG first, and then go to a combination of D2 antagonism with diphenhydramine. And question always arises that why we use diphenhydramine with D2 antagonism at home? The answer is very simple. If they have extrapyramidal symptoms, it counteracts. And that's why all the migraine relief therapies have diphenhydramine in it as well. So give them that autonomy, that use prochlorperazine, compazine, with your NSAID, with diphenhydramine at night, and sleep. And you can use it every 8 hours after that, or 3 nights straight. And then again, that why diphenhydramine is there, if you have dystonic reaction, get another dose and go to the ED. Please note this medication combination can make patient drowsy, and caution should be fully advised. So this is how your plan should be looking at the end when you give the patient with acute plan. Number 1, relief therapy, which is by going in a dark room. Number 2, mild to moderate, NSAID. Moderate to severe, you have to give a triptan with an NSAID. Nausea on top of it, and then the rescue medication. Another thing which is less used is the bridge therapy. That if the patient is at home and you give, then go into status migrainosus often, how do you treat that outpatient? We use multiple ways. The first one is we can use the naproxen ibuprofen bridge. You can use up to 7 days, 10 days, 14 days. It's really tailor-made. Tell them to use back and forth, but with food. Not more than 15 times a month. That's another one. If the patient is using high, decrease the bridge. Number 2, melatonin bridge. 10 milligrams into 5 nights straight. Quetiapine, which is the Seroquel bridge, 25 milligrams into 7 nights straight. Olanzapine, 5 milligrams into 5 days. Prochlorperazine, 10 milligrams TID. And the nerve block can always be added. So now we have acute, rescue, and bridge therapy. And then this is important, what's going on in the world right now for kids as well. We have multiple triptans which have been approved for kids. And you see the youngest is actually it's just 6 years old. So rizatriptan is often prescribed to, in my practice as well, above 6 years old. And then we have some devices as well, which we can be used. Nerve blocks, again, I will strongly recommend Pakistan Headache Society, our Pakistan Neurological Society to train people in nerve blocks. It's something that should be done more often. It provides good relief. It can be used for oxygen neuralgia and also status migrainosus. There is mixed literature about it, but in my practice and the people I've trained with, we use it very often and we have very good results. And lastly, GPANs, which are the upcoming treatments. You might have heard about them. They are CGRP receptor antagonists, calcitonin gene receptor related peptides. They are highly used now. Why they're well sought? Because unlike triptans, they don't cause vasoconstriction, and they're safer in patients with coronary artery disease, stroke, or uncontrolled hypertension, low risk of MOH, and then they also have less side effects like Raynaud's hypertension or GI disturbance, but overall they're very well tolerated. Limitations, they're very expensive, like Nurtec, 75 milligrams, one pill is around $170 right now. With insurance, it comes down, but it's very hard to get it approved as well. And then Ubrelvy is another one, which is also a GPAN. These are small molecules. And the Zavspread is spray. Reason why headache advocacy is so important, we do at Washington, D.C., we go to Capitol Hill, we work with senators and all the Congress people. I totally urge everybody to talk their constituency, go to the federal levels, get more fundings for headache disorders, and also for the medications which are upcoming because they're expensive. Thank you very much. I appreciate your time. If you have any questions, please let me know.
Excellent talk, Dr. Khalid. If anyone has any question, you may ask Dr. Khalid directly.
Sir, I'm Dr. Abil. I'm consultant neurologist from Jamshoro. So my question is that a lot of times when the patients come to us with moderate to severe migraine, then they have a lot of vomiting, nausea and vomiting at that time. So they're not really able to take any oral medication at that time. Many times we're not able to give them any oral medications because they're having so much nausea and vomiting that they're just vomiting it out. whatever we give them orally. So that in that case, what should be our plan actually? Because then everything has to be changed, and we cannot go according to giving NSAIDs and these things. They're just not able to take it, not able to take any of those oral medications. So what should be the plan then in that case?
That's a great question. And it really happens often. And that's where the point that you have to take a step back. Number one, their migraine is not controlled by good prevention. All right. So think about why they're having such severe migraines in the first place. Talk about prevention. Number two, if they come to ED first, you have to control their nausea. You have to give IV medication straight away, right? You can't afford for them to bring them to ED all the time. And that's why you have to give them suppositories sometimes. So are there any suppositories available in Pakistan right now for nausea and vomiting, like Zofran suppository or Reglan? Do we know of any?
So they're not widely available, like they're not available easily, like especially in smaller cities, they're very hard to find.
Okay. And then what's your first line right now for nausea? What do you get?
Sir, in that case, what I prefer personally is start giving them injectable antiemetics, so that I'm able to first, because at that time the most important thing for me is to suppress their vomiting, so that I'm able to give them oral medications after that. So first I start injectable antiemetics. As soon as their nausea or vomiting gets improved, then I start with NSAIDs. And so because here not all of the medications that you mentioned are not easily available here, so it varies center to center. Even in one city it varies center to center, hospitals, between hospitals. So first we have to see the medicines that we have available there, and then we choose accordingly. That's what we do.
Yeah, 100%. Obviously, IM patches. Do you have that?
Sorry, sir?
Patches.
No, sir, we do not have patches
So that's another
available here.
thing.
No, sir, we don't.
Scopolamine patches.
We do not have patches available here easily.
So, yeah. So then the third thing which we do is the education about pre-monitory symptoms. That's very important. So we tell the patients that you have to make a headache log and try to write what comes first for you. Is it fatigue before the aura even? Yawning? Is it craving for sweet or savory? It's irritability. Even at the pre-monitory symptoms, and all the new research, by the way, is being done on the pre-monitory symptoms. All the new medications are being done pre-monitory. So if you have them, take the anti-nausea medications oral. Because your migraine, remember, is generated by the time the pre-monitory starts. So we have just a patient I saw 3 days back that her headache was very rare. It was more the vertigo with nausea, and then also with fatigue that started, and then she had aura. So we started treating with oral medication straight away for her, and she got much better. Because not every patient might have one bothersome symptom and not the other one. So it's correct that you can use IM, but it's not long term, as you were saying. You can't expect the patient to come to the ED every time and then get the medication. So number one, prevention. Talk about prevention, that how you can make things better. If you even have to have a beta blocker, sodium channel blocker, and think in the terms of mechanism of actions. What receptors you are not hitting, okay? If the patient is on a sodium channel blocker, think about that. The second thing is it on an NMD antagonist like magnesium or memantine? Hit on that. The third thing is if the patient is on a sodium or not. The second one maybe, hit on that. And then more importantly, one thing which I've seen in my practice is that patients who are younger, 20s and 30s, they tend to respond really well to two of different kinds of beta blockers. It could be metoprolol or propranolol, and that helps with nausea as well. So try putting on that. And obviously resources scarcity is a big problem, and that's why advocacy is so important at different levels.
Thank you, sir. Thank you.